Good afternoon. I'm going to talk about Moonshot for curing cancer. In the past 2 or 3 months, we've been hearing a lot about an approach from mainly from the Western scientists about finding a cure for cancer. Is it really possible? Can we ever cure cancer? That's what I'm going to talk about. So what exactly is the Moonshot? So when you look at Moonshot, it's a proposal which addresses a huge problem, and it proposes a radical solution and uses breakthrough technology. So the term actually came from in 1961, May 25th, 1961, President Kennedy, a young president elected after a heated election in US, in 1961, he declared that United States is going to land a man on the moon. So that was, he made this declaration at the US Congress. When he made that declaration, United States was far behind Soviet Union in space technology. And there was no person really spent more than half an hour in the space when he declared this. And it was a stunning declaration. But so in 10 years, less than 10 years, United States landed Neil Armstrong and his crew on the moon. So Moonshot is trying to achieve an improbable goal with no clear path ahead. So President Obama, on January 12, 2016, did the same thing. In the presidential address, he said, we're going to find a cure for cancer. And then he turned to Vice President Joe Biden, who lost his son at the age of 46 with a brain tumor, and asked him to be in charge of finding a cure for cancer. That really possible? And that's one. And second, why it's relevant for us in India when the President of the United States declared a moonshot for cure for cancer. That's because cancer is a global problem. It's not just a problem in the United States. And about 1 in 4 people will die from cancer in the US, and 1 in 7 deaths worldwide are due to cancer. And the number of people dying from cancer is substantially increasing across the world. And that's more true in countries like ours in India. Because India is a transition economy. In transition economy, you transition, when you transition from many illnesses of, if I can say, poverty to illnesses of affluence. And cancer is an illness of affluence. So it's going to be a huge problem for us also. And globally, if you look at about 15.2 million people are diagnosed with cancer now. And then about 24 million will get a diagnosis of cancer by 2035. And about 9 million die from cancer, and about 14 million will die from cancer by 2035. So it's a growing, huge problem across the world. And tobacco is unquestionably the most common cause of cancer. And about 30% of cancers are due to tobacco. And usually I tell my students, if people stop smoking, I'll lose my job. And usually I say that I'm absolutely fine with that. And about 20% reduction in mortality by stop or tobacco cessation. Obesity plays a major role. And then other pathogens, which I'm going to talk in a few minutes, and then multiple factors, as you can see, including alcohol and ionizing radiation plays a major role in cancer. So cancer is a disease of lifestyle. And lifestyle plays a huge role in cancer. So what are the really most important topics in cancer today? What are the hot topics now? I think we can say vaccinations are pretty hot topic, genomically driven treatments, and immunotherapy, and big data. So probably these 4 areas are getting more attention in cancer now than anything else. And in cancer, in the understanding of cancer, analyzing cancer, and treatment of cancer, this is a fascinating time. We are making huge progress in controlling cancer at this point because of some of the major advances in cancer treatment. So if you look at, and I'm going to focus on vaccination for a minute, and if you look at vaccination, again, as I said, about close to 20% of cancers worldwide are due to infections. It could be a bacterial infection or viral infection. And bacterial infection, Helicobacter pylori, is a major culprit. Then, of course, hepatitis B, hepatitis C, and human papillomavirus. So, HPV causes, or human papillomavirus causes close to 500,000 cancer cases worldwide. So a viral infection causes 500,000 cases worldwide. And as you know, Helicobacter pylori, a bacterial infection, is a major cause of gastric cancer or cancer of the stomach, and that's very common in India. Hepatitis B, hepatitis C, which is more prevalent in China and Southeast Asia. And then HPV, which is extremely common in India, which can cause multiple cancers, including cervical cancer, anal, vaginal, and penile. And then, as I said, Helicobacter pylori causes gastric, and then hepatitis cancer causes liver cancer. So vaccinations play a key role in prevention of many of these cancers, which includes the HPV-related cancer. And I know that government of India has taken major steps in introducing HPV vaccine in India. And then hepatitis B vaccination is extremely important for prevention or reducing the incidence of hepatitis B. Hepatitis C, we have many amazing treatments available in the past 1 or 2 years. And the issue with hepatitis C treatment is it's extremely expensive, but it's highly effective. So let's look at genomically driven treatments. So I'm going to, so if you look, there are so many things happening. There are many people are talking about genomic testing, genomic profiling. So it's an extremely confusing area. And with Angelina Jolie coming out and talking about her BRCA testing and then planning for a bilateral mastectomy, so it came to the forefront of public discussion in the past 2 years. So as a cancer doctor, what exactly is the meaning of all these things? Or what exactly is helpful for our patients? So genetic testing, which we commonly do, the BRCA testing, that's useful. Genomic profiling of the cancer, especially for breast cancer, that's clinically relevant. And some of the genomic testing using companies such as Foundation Medicine, and I'm sure many companies around the world is offering genomic profiling of the tumors, which are clinically relevant. So briefly, I'll talk about these issues. I'm going to show you some examples. So one of my patients, she has metastatic triple-negative breast cancer. She had brain lesion, which was resected a few months before she came to see me, and she had chemotherapy. But when she came to see me, you can see that the CAT scan is showing fairly extensive disease in the lung. She was hypoxemic, short of breath. She had severe pain because the tumor was invading the chest wall. And her pulse oxygen level was like 87%. She was not able to walk. So this is so here we have a patient with triple-negative breast cancer, which is probably the most aggressive form of breast cancer. So one of the things I talked to the patient at that time was, should we consider doing a genomic profiling of the tumor? And she's about 59 years old, and she has triple-negative breast cancer, and we generally offer genetic testing for those patients. So we did the genomic profiling, and the tumor actually came back as, you can see that in the screen, there are multiple genomic alterations seen, including a BRCA2 in the tumor. So this is from the tumor. At the same time, we ordered for a genetic testing, so that's from the patient. So a germline, and she came back as BRCA2 positive. So now we have a tumor has mutation, that's P10, BRCA2, MYC, T53, and multiple, and then she has BRCA2 positive. So then we enroll her on a clinical trial testing the role of Olaparib, which is a PARP inhibitor for breast cancer. Again, PARP inhibitor. This Olaparib is FDA approved for BRCA mutated ovarian cancer at this point. So this particular trial is looking at the role of Olaparib 300 milligram POBID versus treatment of physician's choice in metastatic breast cancer who have germline BRCA2 mutation. So our patient has germline BRCA2 mutation, and then she was enrolled in this trial. So as I said, it's approved for ovarian cancer at this point. So we started her on, this is the way I saw her, and then in few months of treatment, she had an amazing response. You can see that the tumor is completely melted away from this targeted treatment. So this is genomically driven treatment based upon her genomic profiling, and she's still doing well. This is February 2016, and we just did a scan for her last month. She's doing really well, and she's back to work. I'm going to show you one more example. This is a patient of mine who has, again, BRCA2 mutation, was diagnosed with stage 3 breast cancer, which relapsed a few months after completing treatment. You can see her on the skin redness, and the Band-Aid you're seeing, that's where she had the biopsy done. So she had fairly extensive skin recurrence from breast cancer, and we put her on Olaparib, which is a PARP inhibitor, and she had a complete response. So this is drugs are available. They are highly active and minimally toxic. So I'm going to give you one more example. So this, how we are using genomic testing for treatment planning. So I saw a patient, stage 2 breast cancer, HER2 negative and grade 1. So she had 2.5 centimeter tumor. She had her surgery done, and then she came to us to see if she needs chemotherapy. So in a patient like her, at this point, almost I can say as a standard treatment across United States, and probably, and I'm sure many of you are using these kind of tests in India also, we use Oncotype DX for treatment planning. So before I recommend a treatment for her, I'll tell her, we will send a tumor for Oncotype DX testing, which is about 16 plus 5 genes, and that will predict the chance of recurrence for the next 10 years. So if the patient is in the high risk, she needs chemotherapy. If she's in the low risk, she doesn't need chemotherapy. For this patient, the test came back as in the low risk, and she did not receive chemo. She was treated only with anti-estrogen treatment. And when the beauty of the test is, in addition to giving a recurrence score, it will tell us what's the chance of recurrence for the next 10 years. That relieves the patient's anxiety, that helps us to pick the right or appropriate treatment without exposing the patients to toxic treatments and toxic treatments such as chemotherapy. So if you look at the genomic area, there are many clinical trials coming up at this point. As I said, this is probably one of the really hottest area, many genomically driven trial. I'll give you an example of a genomic driven trial. This is a young lady who came with triple negative, highly aggressive tumor. This is a PET scan. You can see that the tumor is this FTG active area. You can see that the tumor is invading the muscle and then the upper part of the mediastinum. So she has metastatic disease. She had, because she's triple negative, we offered her a PARP trial. The patient declined that. We put her on the standard treatment, and at the same time, we send the tumor for genomic profiling. And we sent for PDX assay too. I'm not going to talk about PDX assay. I'll focus on genomic profiling. So, and this is the genomic profiling, and you can see that she has multiple mutations from the tumor. And so by doing the genomic profiling, we opened up the treatment options for her. You can see that with the mutations in the picture, she was selected for many different options. And one of the options is the signature trial, which was actually run by Novartis at that time, which uses genomic information to select compounds specifically targeting the genomic alteration within the tumor. So the next two, I'm going to briefly touch the next two, the immunotherapy. So we've been talking about immunotherapy for the last probably 60 years. Initially, there was an era of excitement, then skepticism, and then in the past 10 years or so, immunotherapy has shown dramatic improvement in diseases like melanoma, renal cell, which are highly refractory, has multiple treatments FDA approved at this point from immunotherapy. I think that immunotherapy will show an explosion of treatment options in the future. So lastly, big data. So if you look at any field in medicine or any field all over, we are creating so much new data every day. And it's extremely important for us to learn how to analyze this data. That's one. And second, it's extremely important for us to share the data. So let me give you an example. I talked about genomically driven trials and some of the targeted treatments. So those things are from the Western world. And how do we know that that's applicable globally? So by collecting data in appropriate setting and analyzing those data and sharing, that's the only way we can make a better understanding of what's happening in the real world. So I think big data will play a huge role in cancer treatment in the future. So moving on to summary. So if you look at, these are probably the cornerstones of cancer treatment. Precision treatment, such as genomically driven treatment, and immunotherapy are playing a huge role. So in conclusion, we talked about some of the vaccinations, genomically driven treatment, immunotherapy, and big data. So this is from New York Times. Recently, as I said, Joe Biden is in charge, Vice President Joe Biden is in charge of this Moonshot. U.S. is planning for $1 billion. U.S. government is planning for $1 billion for this effort. And I'm sure many private enterprises will be putting billions of dollars in finding a cure. So the last question, are we ever going to cure cancer? I think we will cure some cancer. We are not going to cure all cancers. But what we are going to do is, by a better understanding of the pathogenesis and the evolution of cancer, we are going to find a way to keep it as a chronic disease, like hypertension, or like diabetes mellitus, or like some of the cardiac diseases. I hope that we will be able to convert cancer as a chronic disease. And I thank the effort by private and public funding in finding a cure for or finding a control for cancer. And thank you for your attention. I'll be more than happy to take any questions.
The questions are already shared with you. Can you please take them?
Keshav, can you text me the questions? So I don't see too many of the questions.
Could you see the questions? I mean, we shared a 5-6 question with you.
I'm not seeing the questions, Keshav. I see your question. It said, hello, sir, and that's the only question I see. Can you email me, or I can look that up and I can answer that. Or if you
so let me read out the questions.
Okay.
For all the audience. So this question is from Abhishek. He's asking, what are the risks and limitations of genomic testing?
So Abhishek, that's a really good question. So at this point, I think the marketing effort of genomic testing is actually really overshadowing the reality. So we do genomic profiling of many of our complicated cases at Cleveland Clinic. So what we find is about, when I say genomic profiling of the tumor, in advanced setting, in metastatic setting, probably about 10 to 15% of those genomic testing are clinically useful. Means after doing a genomic profiling, about 10 to 15% of the patients, we can find a right treatment. And sometimes it can be a clinical trial, sometimes it can be an FDA-approved drug. So in metastatic setting or in advanced patients, the genomic testing has to really expand its portfolio of options in the future. But in early stage, as I said, in a patient with stage 2 breast cancer, if you do genomic profiling of the tumor, such as Oncotype DX or MammaPrint, that will clearly give me an answer what type of treatments I need to choose. So that's extremely helpful. I think that will continue to expand in other tumor types. Then thirdly, if I have a patient with high risk or strong family history of cancer, if I do the BRCA testing, that really will help the patient too. So there are probably three scenarios which are extremely helpful, but two scenarios extremely helpful. That's family history, doing BRCA testing, that's helpful. And then early cancers, if you do genomic testing, that'll help me in limiting the treatment toxicity. And third, in metastatic setting, about 10% of patients it can be helpful. So it has huge limitations. It's a good question.
Okay, so the next question is from Dr. Amit Arora. He's asking any therapy that's leading towards moonshot. Leading towards moonshot.
So that's a good question, Dr. Arora. So I think if I say from this point of view, again, this is, and of course I'm from India, but if I say from the Western world's vantage point, from this side, the immunotherapy is making huge impact. I think immunotherapy is probably the most exciting. And second, as I showed some examples, some of the genomically driven treatment are showing promise. So I think those are the two treatments which can potentially help us to the moonshot. But I know that globally, finding a treatment for cancer may not be the only answer. As I mentioned earlier on, prevention, which starts with lifestyle modifications and prevention of infections, vaccinations, improvement in poverty. So I think it's going to be multiple factors. But if you talk purely from a treatment or therapeutic point of view, immunotherapy is extremely exciting, and then some of these novel targeted treatments are extremely exciting.
Okay, this question is from Dr. Rajesh. Is asking in how much time the results of genomic profiling are available for the physician who is treating the patient.
So good question, Dr. Rajesh. So genomic testing, it looks like he's referring to the Oncotype B, some of the tests like Oncotype BX or so. So for us, it takes about 2 to 3 weeks for the test to come back, and that's true for other testing which I mentioned too. About 2 to 3 weeks or so. So usually after the surgery, we see the patient at the cancer center. 2 weeks after the surgery, we see them, and then we send if the patient is the appropriate patient, we send them for oncotype profiling or genomic testing.
This question is from Shatish. The question is, apart from the genomics data analytics, every year we add on new patients. Is there any tool to find who are the next 14 million patients?
So that's the big data. So if you look at, I think data is extremely important. There is, without data, I don't think even the policymakers, the administrators, the business world, physicians, I don't think we can make any impact. And I don't want to say that the Western world has a handle of the data. Western world, we don't have a handle of the data. But we have fairly strong databases. We can say every year we have data coming out from American Cancer Society and World Health Organizations about incidence of cancer across most of the mature most of the countries with mature database, like the Western world. And the US has precise data about cancer incidence in every state, every county, or district, and what type of cancer. I think in India, we really need to work on developing a strong data. And without having a strong data, I don't think we'll be able to charter the plans for our future. And exactly the question you asked, how do we know who's going to come to, who's going to get diagnosed with cancer in the next year or next 10 years?
Rajesh Chandra is asking, when should I ask my doctor about genomic testing and getting the Symphony profile done?
So if for a healthy person doing the genomic testing, that's more applicable if you have a strong family history. And just say you have a strong family history of cancer. So when I say strong family history, especially for women, breast cancer and ovarian cancer at a younger age. For men, let's just say a history of pancreatic cancer, strong history of prostate. So if there are multiple cancers happening in the family at a younger age, they should be considering some kind of genetic counseling, and then a BRCA testing or some of the genomic testing to see if they have inherited a gene. That's one. Second, if you're talking about from a cancer perspective, if somebody already has a diagnosis of cancer, then you have to have this conversation with your oncologist about is this tumor can be profiled, which can potentially offer treatments in the future.
This question is from Rasika Bhatt. The question is, as of today, keeping in mind the cost and access, will immunotherapy and genomic therapy be applied after failure to respond to conventional surgery and chemo in breast cancer?
So that's a really good question. So how can we afford this? So that's why I mentioned before, I'm kind of talking from a Western view. These are extremely expensive treatments. Can every society afford genomically driven treatments or targeted treatments or immunotherapy? Even here in the US, many of these treatments are considered as extremely expensive. Some of these treatments can cost anywhere between, for one treatment, it may cost between $5,000 to $25,000. So we are talking about $500,000 treatment for one patient. As a society, I think every country needs to make a decision about how they're going to approach this huge issue. I think that's a major issue. Here in the Western world, because of the high insurance utilization, it's probably easy. But even then, and again, the patients are not paying this $500,000 because insurances are paying for that. But in countries like India, where it's the patients paying from their pocket, it's a tough choice. I don't think it's an easy decision for the patient or the doctor to prescribe an extremely expensive medicine.
Another question from Dr. Amit Arora. Which is the first cancer anticipated to be cured? Is there a defined timeline?
So, Dr. Arora, I don't think I can say that. So I think we can say overall, so early stage cancers, there are many early stage cancers which can be cured. Early stage breast cancer, some of the lymphomas, some of the leukemias are potentially curable. And as you know, chronic myeloid leukemia, which is kind of considered as an incurable disease or only treated with transplants in the past. Now it's almost converted into a chronic disease because of utilization of drugs like imatinib, tyrosine kinase inhibitors. And then breast cancer, especially the HER2-positive breast cancer, which was at some point considered as the most aggressive form of breast cancer. Now with HER2-directed treatment, it's considered as a chronic disease. So I don't know which is going to be cured first, but some of the early stage cancers we will be able to do that. Again, early stage, and that's another question. In many other parts of the world, most of the cancers come to the doctor's office in stage 3 or stage 4. So public education, awareness of potential treatments for cancer and early detection will play a key role in many economies around the world.
Rashmi is asking, what are the chances of breast cancer reoccurrence after treatment and how can it be avoided?
So that depends on multiple factors. That depends on one, the stage of the cancer. If it's an early stage, we can say, when I say early stage, stage 1 or 2, we can say 80 to 90% or close to, if it's really early stage, almost 95% chance that it's not going to come back. In stage locally advanced, or stage 2B, stage 3, but 60 to 80% chance that it's not going to come back. So again, it clearly depends upon the stage, that's one. Second, the biology. There are many other features within the tumor, such as ER, PR, HER2, grade of the tumor need to be addressed. Again, triple negative patients have high chance of recurrence versus ER, PR, or HER2, ER positive. HER2 positive has high chance of recurrence, but with the utilization of HER2 targeted treatments, it's less. So again, multiple factors influence. That's one. And appropriate treatment is extremely important with the type of cancer you have, whomever has. That's one. And second, to avoid, again, in cancer survivors, we talked to them about keeping a healthy lifestyle, such as maintaining a healthy weight. That's extremely important. Exercise and managing their diet, because healthy lifestyle and managing their diet and exercise will cut down, if I can say, increased circulating estrogen level in the body, and that will cut down the chance of recurrence. And we see that even in triple negative patients.
We'll probably take a couple of more questions. How important is tailoring treatment for individual patients with early stage breast cancer?
Keshav, can you repeat that question for me, please?
The question is, how important is tailoring treatment for individual patients with early stage breast cancer?
Right, that's a good question. So, so when we talk about cancer treatment, it's always really individualized. It's not the same treatment for every patient. So let's just say if you're seeing somebody, let's just say we are seeing somebody who is 35 years old with a stage 2 breast cancer with a triple negative or ER/PR and HER2 negative, then that's a more aggressive tumor. And that should be treated more aggressively. Let's just say if I'm seeing who is 75 years old, stage 1 cancer, the treatment should, the tumor should not be treated too aggressively because the tumor in general, older patients have a less aggressive tumor. And the treatment should be tailored according to that person's age, the stage of the tumor, the biological factors, and the comorbid conditions. Let's just say if the patient has multiple medical problems, and there are multiple competing mortality or morbidity. We should really take that into account before planning for the treatment. So treatment for cancer or breast cancer, any cancers, it's highly individualized.
This is from Dr. Richard. The question is, what is the approximate cost range for performing genomic profiling?
So, so for Oncotype test, which we usually do for assessing what's the risk of recurrence for a tumor, especially ER positive, HER2 negative, here it's about $3,500. So for a BRCA testing, it's roughly again in the same range, $3,000 to $4,000. And then for a genomic profiling of a metastatic tumor, it's again in the range of $3,000 to $5,000.
Abhishek is asking, do I need chemotherapy for invasive breast cancer?
So, if the so this is the way we decide. Again, if it's early stage, ER positive, estrogen receptor positive, HER2 negative, in large number of patients, we can treat them with anti-estrogen treatments only. We don't have to use chemotherapy. In patients whom we are trying to make decisions, tests like Oncotype will help us in deciding if they need chemotherapy. So not all patients with invasive cancer requires chemo. And that's, as I was mentioning before, the treatment needs to be individualized based upon the patient characteristics and the tumor characteristics. And that's a good question, because the misunderstanding is everybody with an invasive cancer, invasive breast cancer, needs chemo. The answer is no. We can tailor the treatment based upon the biology of the tumor.
We'll take this last question. This is from Satish. What's your opinion on liquid biopsy? And the second is microRNA testing.
Right. That's a good question. So we've been talking about liquid biopsy for a long time, for the last probably 5 or 10 years. I don't think the liquid biopsy has reached the clinics or the patients yet. But I think that will be extremely helpful or valuable. So I'll give you an example. Let's just say if we are seeing a patient when we are treating them, let's just say if by doing liquid biopsy periodically, when we are taking the blood, analyzing the serum, we can monitor if the patient is responding to that treatment. We don't have to do a CT scan or a PET scan every so often to see if the patient is responding to the treatment. So that's one. And second, if the patient is developing resistance to treatment, we should be able to find that early on by doing a liquid biopsy. I mean, at this point, the only way we can find about resistance is if the patient is not responding. That's one. And second, by doing, of course, doing repeat scans. And then third, probably doing a biopsy, which is more invasive. So having access to a liquid biopsy will prevent that. And then there was a question about how do we monitor if the patient is going to recur. So if we have options of doing blood tests to find out early recurrence, that can potentially allow us to intervene early on. So I think access and developing liquid biopsies will be an extremely important step for early detection, prevention,